Good morning, everyone. The last session ran a little bit late, but I guess we need to start on time anyways. And it's a pleasure for me to moderate a very, very interesting session, a pro-con debate on the question whether there's still a place for artificial colloid solutions in the perioperative setting. I would say that is one of the hot topics in the field of perioperative medicine, and it's a pleasure to welcome two excellent speakers. One is Professor Alexander Joosten from Paris, and the other one is Professor Matthias Herringlage from Germany. So we will have the pro part first and then followed by the con part. But before we start the talks, I would like to ask you the questions, and I will ask you the same question at the end of the talk. Could everybody raise his or her hand who thinks that there still is a place for artificial colloids in the perioperative setting? So please raise your hand if you think there is a place. Okay, we will see if that changes after your talks. And Alex, I would like to welcome you on the stage and ask you to start with the pro
Thank
part.
you very much. So as you said, I am originally from Belgium, from Erasmus Hospital, but I've been at Bicêtre and now Paul Brousse Hospital in Paris since the past 3 years. So of course I have to disclose some conflict of interest that you should keep in mind in view of this presentation. So artificial colloid solutions have been developed to progressively replace, of course, albumin solution, which is considered as the colloid of reference. Dextran, due to allergies and coagulation disorder, they have been almost abundant. Gelatins, they are derived from bovine collagen, but they have a shorter action compared to starch. And also, we have very few studies on this kind of solution. And therefore, mainly the artificial colloid solution, which is not really artificial because you can see that they are plant-based solution. So it's not really synthetic solution. They are starch or hydroxyethyl starch. So we'll, of course, discuss about this. As we all know, there have been considerable controversy on the use of hydroxyethyl starch in the intensive care settings, showing an increased mortality and acute kidney injury in this patient population. And recently, the European Medicine Agency even tried to restrict its use in the perioperative settings. But if you look to surgical patients, here with several meta-analyses, we could not observe the same thing. There is no worse outcome. So can we still use starch solution in operating room patients? That's a real question. Usually we use crystalloid, and we often hear it's the ideal resuscitation fluid for all situations. We can give them generously, there is no adverse effect, and they are cheap. But is it really a perfect resuscitation fluid? Do you think we have an ideal resuscitation fluid that can produce a predictable and sustained increase in intravascular volume, have a chemical composition as close as possible to the extracellular fluid, be metabolized and completely excreted without accumulation, do not produce adverse metabolic effect, and be cost-effective? Of course not. But now, imagine that we have this perfect solution. Do you think that we as clinicians will be happy to have one single solution, for example, saline or Ranger lactate, that can fit all this situation? Of course not. So give them generously, they have no adverse effect. No, what we know, it's pretty old studies, but following major surgery, patients often have a weight gain of 3 to 6 kilograms. And what we also know is that there is a relationship between the infusion of crystalloid and weight gain, and also between weight gain and postoperative morbidity and mortality. What we also know is that the way we give crystalloid and the amount we give during surgery is a strong predictor of ARDS, as you can see in this slide, and we can have an impact on this. And finally, we know that the higher the fluid balance is, here more than 2 liters after surgery, and you have an increased risk of postoperative organ dysfunction, cardiovascular, neurological, respiratory, and infection complication, as well as ICU length of stay. So, you know, the debate between crystalloid and colloids, it's an old debate, but now we can even see some debate inside this type of category between saline and balanced solution and between albumin and artificial colloids. All have, of course, their own advantage and disadvantage. But the most important for starch solution is that the volume effects are context sensitive. It means that in face of a hemorrhage, the ratio would be 3:1, while in the context of volume loading, so during the optimization of our high-risk surgical patient, the ratio is rather 1.5:1. And this has been confirmed 3 years later in this systematic review and meta-regression. So what is very important for surgical patients is that we all know that there are 4 phases of intravenous fluid therapy, with the rescue phase, the optimization phase, of course, the stabilization phase, and the de-escalation phase. But we, in the operating room, we are mainly the optimization phase, and our main objective is to optimize and maintain tissue perfusion. And in this context, we have to follow hemodynamic protocol and optimize fluid therapy using what we call goal-directed therapy. And in this context, artificial colloid have been the most used study solution. In the context of perioperative goal-directed therapy, we have only 5 prospective randomized controlled trials that have compared the efficacy and safety of colloids versus crystalloid when using a protocol to guide fluid administration in patients undergoing major abdominal surgery. In the first one, it was a pilot study. The author used a baseline crystalloid administration and then fluid bolus of starch to optimize stroke volume. Of course, they didn't show any advantage or disadvantage of one of the other solution on patient outcome. So no beneficial effect on patient outcome. In the other study, Yates and colleagues showed the same thing. No beneficial effect of starch on patient outcome. In the first study, a large single-center, multi-center study, including more than 1,000 patients undergoing moderate to high-risk abdominal surgery, once again, the author showed no difference in patient outcome. In the last study published in the JAMA, Fucci and colleagues in a double-blind study, including more than 800 patients, showed, once again, that there is no difference in patient outcome. But in all of these studies, what they showed is that to obtain the same hemodynamic effect, you have to give less colloid than crystalloids. And finally, my group, in a bicenter randomized double-blind controlled trial using an automated fluid administration system, we demonstrated that there is a positive effect of starch. So we use an automated system, and the bolus were guided by a computer to, of course, withdraw the investigator bias and, of course, variation in practice. So the primary outcome was the postoperative morbidity scores, which is a 9-domain scale on postoperative day 2, and this score was less, of course, in the colloid group. And it was confirmed as secondary outcome with the incidence, or lower incidence of major and minor postoperative complication. Why? Because patients in the colloid group receive less fluid during surgery and has a lower fluid balance during surgery. And this, even if they receive less vasopressor, and in the ICU, fewer patients had a lactate above 2. But very importantly, the closed loop optimized both groups in the same way. The goal was to optimize stroke volume. So the system gave, in both groups, the study fluid in a blinded way in order to optimize stroke volume. But to do this, the system administered more crystalloid than colloids. So when fluid optimization was standardized and guided by a closed-loop system to limit the risk of investigator bias, a colloid was associated with fewer postoperative complications. So what do you think is the main difference between my study and the other study? It's the compliance to the administration of the fluid. In this larger study on goal-directed fluid therapy, the author couldn't show a clear beneficial effect of goal-directed therapy on patient outcome. But when they adjust the result on protocol compliance, the result became significant. It means that it's not very easy for clinicians to follow a hemodynamic protocol and to guide fluid administration consistently in both groups. But what we know is that it's a huge problem, compliance, because even in study conditions, it's often below 50%. So imagine what it could be in real life without any study condition. But what we know is that we need to have more than 80% compliance rate to see most improved outcome. So we use an automated system when we monitor a patient with advanced hemodynamic monitoring, which is linked to a computer. The computer is linked to an infusion pump, and the system is going to deliver automatically meaningfully challenge in order to optimize stroke volume. And here you have a short video of the system. You can see the infusion pump, the hemodynamic monitoring, which is delivering a bolus of fluid, and this is linked to the computer with all the blue lines here being a mini-fluid challenge. So what did the guideline say? We need balanced crystalloid alone, just for short duration or low risk or moderate risk surgical patient. But for surgical procedure, long surgery, complex surgery, high-risk abdominal surgery, for example, or orthopedic surgery, it's better to use a combination of crystalloid and colloids. Why? It's because, of course, you may have a lot of fluid shift, blood loss, and this is better optimized with colloids. And here, with the German recommendation, they said that based on the available evidence, there is no, of course, association of starch with acute kidney injury. So to conclude, yes, there is still a place of starch solution in the operating room. Why? It's because we all know that if we give exclusively only crystalloid, we may have a higher fluid balance and the association with postoperative complication. How much? I would like to say that with starch, we can try to decrease the amount and probably to titrate, as I did, per 100 milliliters. What type fluid are drugs? So be aware of this. Patient, I think, needs crystalloids and colloids, especially if it's a complex surgery. Balanced crystalloid for maintenance fluid therapy to compensate for perspiration, and of course colloid for volume replacement to compensate blood losses and for restoration of cardiac preload. The most important is that you give it in a rational way, not in patients with pre-existing renal dysfunction, only when indicated, and probably I can show you that using any kind of assisted fluid management system can help. And in this situation, probably any types of fluid are not very dangerous, but it's rather the volume of fluid that we give which are more dangerous. Thank you very much.
Alex, thank you very much for this very enthusiastic and passionate talk pro artificial colloids, and now we will hear the con part, and we will have a discussion with both of you afterwards. Matthias, the stage is yours.
And thank you very much, dear colleagues. In part, we agree, but there are slight differences, and I will try to go into some of these details of the differences, especially that synthetic colloids are toxic. This is something that has been largely ignored, and if shown a bundle of studies, they're all neutral, but there is no benefit except the approach to use this in a goal-directed and precise fashion. And I'm deeply convinced that we need colloids in major surgery, but why don't we use albumin? So this is an animal experiment. These are tubular cells, and they're exposed to hydroxyate starch. And what you can see is a dose-dependent increase in cytotoxicity and a dose-dependent increase in viability of the cells. So it's probably not good to have a synthetic colloid like hydroxyate starch on a kidney tubule cell. Comparably, it's not good to infuse this solution into a rat because you will end up with a decrease in glomerular filtration rate, an increase in renal injury score, and thereby probably you will end up with an AKI. Unfortunately, the rats were sacrificed a little bit too early before they could go to the respiratory for renal replacement therapy. We've seen this also in an unfortunately unpublished experiment on the isolated perfused rat kidney. But the story is probably a little bit more complex because what you can see is slightly difficult from the back, but on the left part is the control, and then there are three bars showing the effects of higher, medium, and low dose hydroxy 2-starch 6%. And on the right side, you can see the effects of gelatin solution. And with the exception of the relatively low dose of hydroxy 2-starch, there is a decrease in glomerular filtration rate. And that especially in the gelatin group, it starts rather early. So this is something I can do relatively fast because Alex was so kind to present some of the data, but he didn't show the complete story. And this is something that makes me a little bit angry almost every time I read a study dealing with synthetic colloids and especially hydroxy 2-starch. Because this is, as you can see on the right side, the conclusion. We did not find any adverse effect associated with the treatment with hydroxy 2-starch. But if you go for the supplement, what do we find? The study endpoint was 14 days, but after 28 days, we see a higher increase in renal dysfunction in the patients treated with a synthetic colloid. It would have been interesting for the readers to have seen this highlighted in the article. Honestly, it's written in the article. It's a small part in the methods, in the results section, but it's really not perfect style to ignore such an important information in a major journal like JAMA and such an important publication. And this is something that goes through the whole story of hydroxy 2-starch studies. For example, this one, a comparison study looking for the deleterious effects of starches on kidney function. What did our colleagues do? They compared older starches with newer starches. They compared starches with gelatins, and they entered also some studies comparing hydroxy 2-starches and non-synthetic colloids. And as you can see, there is no difference published in anesthesiology, but if you look for the real changes in creatinine, what you find is that all the patients treated with synthetic colloids had an increase in creatinine after the study as the endpoint, while this was not the case if they were not treated with synthetic colloids. Again, a little bit difficult at least. And, well, here we have the already cited studies on goal-directed optimization. Of course, there is no hint for acute kidney injury. This was a sparse event in all these patients, and they were treated with relatively low amounts of starches. In contrast, another goal-directed optimization study from Munich using the transpulmonary thermodilution technology in high-risk major surgical patients. They tried to show that this concept works. Actually, it didn't work. There was no difference in renal function in the patients treated with a transpulmonary, with a PICO system. But what was found in the multivariate analysis, risk factors for AKI, the use of starches. So again, a hint, it's probably not a wise thing to use a synthetic colloid in larger amounts in a patient. And what we know, if you use this liberally, we'll end up with a problem. This has been elegantly shown by some colleagues in Jena some years ago, but they used relatively large observation periods of 2 years when they changed the management from hydroxy 2-starch to gelatin to a balanced solution. And what they found was, besides they used tremendous amounts of these fluids, 20 liters, up to 20 liters crystalloid in the perioperative period of a cardiac surgical patient is really astonishing for me. But nonetheless, they showed in this extreme experimental conditions, more or less, that hydroxy 2-starch as well as gelatin increased the risk of acute kidney injury, and gelatin even increased mortality in these patients if you use it in relatively high doses. other studies, and there are multiple you can find in PubMed, show that the withdrawal of hydroxyethyl starch and using an alternative regimen, usually consisting of a crystalloid and some more albumin, reduces the incidence of acute kidney injury. Same observation we did with gelatin at a time when we used relatively large amounts of gelatin and a little bit of hydroxyethyl starch in an observational trial in which the patients were followed relatively detailed. And what we observed was gelatin was an independent predictor of acute kidney injury, and as you can see on the right side, it was dose dependent. The more you give, the higher is the probability that your patient will end up with acute kidney injury. And this is probably one of the larger, most recent observational trials on this interaction between synthetic colloids and adverse outcomes, almost 9,000 patients. And again, while the abstract states there is no difference, if you go a little bit more into the details of this, you will find that there is indeed, easier to see here, a decrease in glomerular filtration rate treated with the patients, in the patients treated with hydroxyethyl starches. Again, a hint, it's probably not a good idea to use these drugs. And, well, we have this problem. We have a trend towards edema if we give too much crystalloid. And this has been highlighted in a Langendorf preparation some years ago by the colleagues from Munich that were already cited, Chappell and Jakob. And they showed that the amount of edema is least with the use of albumin, and if you use hydroxyethyl starch, it's intermediate, but if you use crystalloid, you end up with a tremendous type of edema. And this is, of course, not a good idea, or also shown. This study has also been shown. If you give too much of this crystalloid, you will lose the endothelial surface layer. You can give some additional albumin to bring it back, but this approach leads to a tremendous increase in interstitial edema. This is not good for our patients. And something we also have to take into account, many patients enter the OR hypoalbuminemic. And we know hypoalbuminemia is a predictor for an adverse outcome in regards mortality and morbidity. What will happen to these patients if they get an add-on by a synthetic colloid? And even if we give a little bit of albumin, 20% or 5% in the OR, in a regular cardiac surgical patient, you will see there is some sort of hypoalbuminemia, and a moderate dose is even not capable to restore this. You have to give relatively large amounts of this drug. And we have a bundle of studies that show a benefit of using albumin in the perioperative period. Even relatively recent registered data from Andy Shaw, who's the current president of the SCA. There is a benefit to use these drugs in the OR. You can reduce the incidence of acute kidney injury in the hypoalbuminemic patient, and thereby it's probably not a bad idea. So my perspective is clear. We should not use synthetic colloids in the OR. They're nephrotoxic. They're not physiological. They are not capable to restore albumin levels in a patient who doesn't have enough albumin on board. And they have never shown to be superior to natural colloids. They are always comparable to something else that may be not optimal. And of course, we have to be restrictive, not to overload our patients, but this can be ideally accomplished by using albumin 20%. Thank you very much for your attention.
Thank you very much for your perspective and your arguments against the use of artificial colloids, but for albumin. I would ask you both to the stage, and before we can take questions from the floor, I would like to repeat the question from the beginning. So who of you think that there is still a place for artificial colloids in the perioperative setting? Did anybody change his or her opinion? Any questions from you to the speakers, or any comments, or any suggestion how to treat hypovolemia in the OR, or any experiences that you would like to share from your practice? No question. Then I will start with one. You showed that, Matthias, you showed that we should look not only at short-term outcome, so not only the first 7 or 14 days after surgery, but also you showed the first 30 days after surgery. But if we, think what we want to achieve in our patients, we want to achieve a good long-term outcome in terms of months or even years after surgery. What is the opinion of both of you on long-term outcome and the use of crystalloids or colloids?
Actually, the data on this are in the OR setting are, to my knowledge, relatively spare. And we know from the sepsis studies that there was a trend towards a long-term nephrotoxic effect for hydroxy-2 starch. And we also know that especially in those that enter the OR with a chronic kidney disease that are at risk for acute on chronic AKI, they may suffer really in the long term because the kidneys rarely come back to a normal or the preoperative baseline again. So in these patients, and they have not been adequately studied with these drugs right now, the risk that may give a nephrotoxic substance may even be tremendously pronounced. So this is probably, again, a point to use albumin, because we know this is not nephrotoxic.
Alex, your take on this?
Yeah, so we have, so once again, it's important to separate, I think, ICU patient to OR patient, because these completely two different patient population. But in the OR, we have two studies looking at 6 months and 1 year renal function after initial administration of crystalloid versus starch. And in both studies, there is no difference in long-term renal function. So once again, patient is different, and probably we in the OR, we titrate a little more than in the ICU, old ICU studies when they just open, the perfusion, and we give per 100, 250 in most of the studies, when they gave, as you know, per 500 ml, even if patient did not require any fluid administration. Yeah. So in the OR, long-term renal function, there is no evidence that there is a deterioration of renal function with starch.
But if I remember correctly, these studies were relatively small, weren't they?
Yeah, my study was 160 patients, so it's small, but the one of Cabon and Sessler, they include 1,000 patients. They just look at 6 months and just have a look to the creatinine levels, and they did not increase. But they didn't show any difference also at 30 days.
Thank you. Any questions from the audience? If not, I would have a follow-up question. Perhaps both of you or one of you may comment on what is at the moment recommended by the European Society of Anesthesiology, because there's a clear recommendation and, a kind of strict approach when to use starches. Your opinion on the recommendations of the European Society?
Please start first.
Yeah, so as you know, there are some recommendations about using starch. First of all, you have to do a kind of test to see if you have the knowledge, but otherwise you don't have to use it when patient has a pre-op renal dysfunction, septic patient, burn patient, etc. So there are some restrictions, but I think that if you have the knowledge, if patient bleed, I think that all of us who have used some kind of colloids, artificial or even albumin, we know that they are effective in restoring cardiac preload and can help us decrease the amount of fluid given and, of course, decrease the fluid balance at the end of the surgery.
At our institution, it's no problem because we simply don't have hydroxy-2 starch anymore. And so what we do, we use albumin 20%. It has a much more pronounced fluid volume effect. And if you have someone who really needs immediate fluid resuscitation, you're much faster than with any bottle of hydroxy-2 starch.
At our institution, we follow more or less the recommendation of the European Society, and we still use it in patients with acute severe bleeding when they don't have any contraindication, and all of our anesthesiologists need to take this certification once a year. Of course, a follow-up question, if you promote the use of albumin, are the costs? I think, at least in my institution and country, costs are an issue with albumin. How do you tackle this problem?
With a bundle of emails and emails with the administration, of course, but we have a problem in this, especially in Germany, because if you look for the co-authors of most of these hydroxy-2 starch papers, then plenty of them are at a high level of the German Association of Anesthesia, and they are completely probably thorn between, on one hand, the need for a colloid, and on the other side, the costs they have to face and they have to justify. And for reasons I really do not understand, in the German DRG system, it's not possible to get a reimbursement for the application of albumin, even in someone who's severely hypoalbuminemic, if and cirrhotic, or for example. You don't get any euro for this. And this is something we probably have to change on the higher levels of our associations, because it's really crazy. You get money for plenty of things in the German DRG system that are by far not that physiological and reasonable, like the application of albumin, and this needs to be changed.
Thank you very much. In the interest of time and because people are pushing in for the next session, I thank you both again for this very interesting talks. I learned a lot. I hope you learned a lot too. And well, thank you too again. And for the audience, enjoy the rest of the conference. Thank you.